Influenza season and ARDS after cardiac surgery. Definition. Undergoing cardiac surgery during the influenza season is associated with increased likelihood of development of acute respiratory distress syndrome. ARDS. Acute respiratory distress syndrome, or ARDS, is a serious inflammatory lesion of the lungs that causes dangerously low levels of oxygen in the blood, called hypoxemia. ARDS can lead to a number of serious problems. It is deadly, so the attention is needed.
I take a little listen to your lungs too.
For almost 2 months, a critical care unit was home to Sean Krause, but he doesn't remember any of it.
I believe I was under for 45 days.
Unconscious, on a ventilator to help him breathe, after a case of the flu turned into a potentially deadly condition called ARDS.
It's an acronym for acute respiratory distress syndrome, which it's a form of acute lung injury. In other words, the lung, the tissue of the lung has been injured by something. And this is kind of the classic ARDS picture where we have these dense consolidations on both sides of the lung.
Mayo Clinic Dr. Richard Oakler says that something could be a traumatic injury, a bacterial infection, or in this case, a flu virus.
And sets off a big inflammatory response. And that inflammatory response is really at the heart of this ARDS.
Here's what happens. Your lungs are made up of millions of tiny air sacs. They're in constant contact with your bloodstream, which carries oxygen throughout your body. Normally, barriers prevent water in your bloodstream from flowing into your lungs. When ARDS strikes, barriers break and fluid fills your lungs.
That brisk inflammatory response in the lung now can pass through the bloodstream and throughout the body. And so you get a bad systemic response that can lead to other organ failures and ultimately the death.
Dr. Oakler says close to 40% of all people who develop ARDS don't make it.
I think my lucky stars now, I know that.
Sean's treatment included medication to target the underlying infection and a ventilator to support his lungs.
Ventilators or the breathing machines are really life-saving because we were really able with the machine to help him breathe while his lungs were healing.
Dr. Jeff Rabotin heads the respiratory care unit at Mayo Clinic. He says for many patients like Sean, ARDS can be very tough. There was a time, Sean says, when his family gathered because things looked grim.
They didn't expect me to live. Because I know how close I was to, pushing daisies, if you want to say.
But Sean did pull through. Every day he's getting stronger, healthier, and ready to head home. Back to life.
I'm just thankful to be here.
For Mayo Clinic News Network, I'm Vivian Williams.
One such risk factor might be asymptomatic respiratory viral infection, for example, influenza, which could prime the lungs for ARDS in patients with another other risk factor. All ARDS cases occurred within the first 26 hours after surgery. Cardiac surgery during influenza season compared with vaccine seasons was an independent risk factor for development of ARDS.
Encounter may develop acute respiratory distress syndrome, also known as ARDS. In ARDS, the affected part of the lung is not the airways. Rather, the affected part of the lung is at the alveolar level. ARDS is caused by leaking of fluids into the tiny alveolar sacs of the lungs. So, for example, here is one magnified alveolus. And normally, oxygen that is inhaled into the alveolus is supposed to diffuse into the blood so that the blood can deliver the oxygen to the body. But in ARDS, fluids fill the air sac. The integrity of some of the alveoli will be compromised, often leading to alveolar collapse or atelectasis. And this will ultimately compromise gas exchange. So as a result of diffuse alveolar collapse, the lung will appear to shrink on a chest x-ray film. Collapsed alveoli may also result in refractory hypoxemia. Refractory hypoxemia is hypoxemia that does not correct with the administration of supplemental oxygen. In other words, you can try to administer high levels of FiO2, but because the alveolus is collapsed and compromised, oxygen concentration alone will not correct the hypoxemia. Correcting refractory hypoxemia will require a recruitment of the alveolus, which is a reopening or a restabilizing of the collapsed alveolus. The oxygenation status of the patient is also one of the ways in which we classify the severity of ARDS. So to determine the oxygenation status, the clinician should perform the PF ratio, which is simply the PaO2 divided by the FiO2 of the patient. Here, you can see the classification of the severity of ARDS, as well as the mortality risk. So, improving oxygenation will be one of the challenges in treating ARDS. But how can we get oxygen in if patients with ARDS have a difficult time getting volume into their lungs due to the fact that the alveoli are collapsed? Reopening collapsed alveoli will require an immense amount of patient effort. Additionally, the lung will tend to recoil upon inhalation. In other words, even if the patient does inhale volume, the lung will immediately want to recoil and exhale. This ultimately leads to shallow and rapid breathing. So that begs the question, what are some strategies in modifying our ventilator settings and treating patients with ARDS? And the answer to this question is coming up in the next lessons, so stay tuned.
So I hope you like.
Advantage. If the ARDS is acute, it can be cured in a matter of days or weeks. Early and prolonged use of mechanical ventilation in the prone position significantly improved mortality rates in patients with severe ARDS. Disadvantage. There may be complications such as blood clots, pneumothorax, infections, and pulmonary fibrosis. Issue applied in Ecuador. In annual flu epidemics, attack rates can range from 5% to 20% in the general community and up to more than 55% in closed population groups.
My name is Paul Landry Aronson. I'm an MD at the Yale School of Medicine in the departments of Pediatrics and Emergency Medicine. This topic is acute respiratory distress syndrome, otherwise known as ARDS. ARDS is an acute, diffuse inflammatory injury of the lungs that results in widespread increased pulmonary vascular permeability and leakage of fluid. This results in non-cardiogenic pulmonary edema with decreased lung compliance, loss of aerated lung tissue, hypoxemia, and the classic chest X-ray findings of bilateral coalescent opacities as seen here in this chest X-ray. Histologic findings include diffuse alveolar damage and hyaline membrane formation. Causes of ARDS include sepsis, pneumonia, aspiration, such as from drowning, smoke, or vomitus, or trauma, with sepsis being the #1 cause. Symptoms and signs of ARDS include shortness of breath, tachypnea, retractions, respiratory distress, and on exam, bilateral crackles, often with decreased breath sounds. In addition, the patient may have hypoxemia that may not respond to O2 or administered oxygen. In addition, the patient may exhibit symptoms or signs of the underlying cause, for example, sepsis. Now, the evaluation of ARDS involves the following. An arterial blood gas should be obtained to be able to calculate the PaO2 to FiO2 ratio, which is the ratio of the partial pressure of oxygen in the arterial blood relative to the fraction of inspired oxygen being delivered to the patient. As the PaO2 decreases relative to the FiO2, the PaO2 to FiO2 ratio will decrease, and a ratio of less than 300 indicates ARDS, with less than 100 meaning severe ARDS. A chest X-ray is obtained and will demonstrate the bilateral coalescent opacities as described previously. Additionally, any evaluation for an underlying cause should be undertaken. The mainstay of therapy for ARDS is mechanical ventilation, with a goal tidal volume of 6 mL per kilogram, which is required to adequately ventilate the lungs while minimizing ventilator-induced lung injury. A high positive end expiratory pressure, or PEEP, is often required to achieve adequate oxygenation during mechanical ventilation. It is really important to also treat the underlying cause. However, despite these maneuvers, ARDS is associated with a high mortality rate.
Conclusion. For the relationship that we found between influenza season and ARDS after cardiac surgery to be of clinical value, research is needed to determine whether perioperative strategies aimed at preventing, detecting, or treating subclinical influenza might reduce the number of patients in whom ARDS develops.